Hello, the time is now 1 o'clock Eastern. This is the official start time for today's broadcast. The topic is physician integration along the patient safety spectrum, from preschool to PhD, and we're honored to have Dr. Dan Sullivan here with us today to present. Before I hand things over to Dr. Sullivan, I have just a few items of housekeeping to cover. For technical assistance, please chat directly with RSQ Solutions, or you can email me, jhurley@thesullivangroup.com. If you have any ideas or requests for future topics, you can email me. We'll also have a short form that will pop up at the conclusion of today's events where you can share your thoughts with us. We'd love to hear from you. We will have a Q&A following today's presentation. We are a little crunched on time, so we know we've allowed 30 minutes for today's quick-and-R of sorts, and we'd like to invite you to stay on with us. Dr. Sullivan has agreed to stay on to answer questions following the presentation, and of course, if you have lingering questions, you can always follow back up with us. We'll have a short evaluation, as I mentioned, that will pop up at the conclusion of the event, so please share your thoughts with us. We do encourage you to submit questions at any time during the presentation. While we do have all the lines muted, we're in presentation mode, we invite you to share those burning questions with us using the WebEx chat or WebEx Q&A feature. We'll hold those in the queue and we'll answer them as time allows, and if we run out of time, we will certainly follow back up with you. So now, without further ado, I'd like to hand things over to today's presenter, Dr. Dan Sullivan, the President and CEO of the Sullivan Group. So, Dr. Sullivan, I'm going to hand you the ball, and the floor is yours.
All right, I've got it, Jen. Thank you very much. Thanks for the introduction. And quick-and-R, I love that. I've never heard that before, but that's certainly what this is. And some very interesting message in 30 minutes, so I'm going to jump right in here. I'm Dan Sullivan. This is physician integration along the patient safety spectrum, from preschool to PhD. I think you'll enjoy this. This was fun talking to a number of our clients along the transformation spectrum. So where did this come from? We go to trade conferences all the time. I'm sitting at a nice luncheon at a beautiful resort. I'm sitting with a risk manager from a large organization who's very excited and says, hey, good news, we just employed 1,000 physicians. And then she says, oops, bad news. What are we going to do with 1,000 physicians? And so I thought, very interesting. Maybe we should reach out to organizations who are in this process and ask them how they're dealing with integrating or onboarding physicians. We think we have some ideas, but we thought we'd let them take us to school. So for today's discussion, we're going to describe the marketplace drivers that have catalyzed the current transformation of healthcare, discuss the several stages of integration or onboarding of employed medical staff from a risk and safety perspective. Develop an awareness of your location on the transformation spectrum, and create a vision for an organizational culture based on the National Patient Safety Agenda. So that's a lot for a 30-minute time frame. Hold on one second here. Okay, there we go. So let's start with this. Why the transformation? Well, there's been a lot of white papers, journal articles. Much has been said, but simply the transformation is underway. The new reimbursement paradigm is driving a new construct, a new organizational structure. Quality, safety, satisfaction, hospital-acquired conditions, readmission, value-based purchasing, and others require an unprecedented level of organizational coordination. It simply is not possible to divvy up the fee-for-service pie any longer. Inpatient is moving to outpatient. Those who transform will win, and those who don't will not. So again, we've got the good news, bad news. What are we going to do with these employed physicians? Where do we start? How do we onboard these practitioners? Is it basic blocking and tackling the elements of a medical malpractice action, handoffs, communications. When do we get to the more sophisticated culture-related issues, cyber, HIPAA, just culture, and deal with the high-risk clinical specialties? So as I said, let's reach out to leadership in this country in risk safety and quality. Let's let these folks take us to school, those who are on the spectrum. And maybe as we work through this, you'll see where you're at on the spectrum. And I think most interestingly, as you move from left to right across the spectrum, from preschool to PhD, what that looks like and what the National Patient Safety Agenda looks like and is telling us. So here was our question as we reached out to risk safety and quality leadership in this country. I'm curious, as health systems employ or create closer relationships with the medical staff, often taking responsibility for ensuring those practitioners, what efforts have you made to level set, or what are the most significant or current pain points, problems, and risks? If you could wave your wand and get them all on board with understanding certain key issues spanning all specialties, what would you want them to know or be aware of? Is it key to successful communication, handoffs, documentation essentials? Is it patient satisfaction, cyber, medication errors, risk, electronic health records, more general medical legal issues? And I was just naming a few in the conversation to get their wheels turning and help bring them into the conversation. So let's turn to our teachers and run through 4 stories, which I think you'll find very interesting and sort of point out points on the spectrum from preschool to PhD on onboarding and integration in patient safety culture. So first organization, short story. 38 hospitals recently spun off from a far larger organization, multi-state, largely Midwest, 400 employed physicians. And I put about the risk manager because this is a true veteran in risk and safety in our country. He has been the risk manager for a huge organization responsible for many programs and now finds himself in a new organization, 38 hospitals, and this is what I said. I knew he was new, wasn't sure exactly what he would be doing at the inception of this organization, but I thought, well, it's the beginning of the spectrum. So, what are you up to? Have you been giving it some thought? Yes, Dr. D, I have given it some thought. As of 6 months ago, I took on responsibility for 400 employed physicians, and honestly, I have no idea yet what the integration strategy will be. I still don't know who we insure, what docs have their own insurance. We are still addressing the basic fundamentals of starting a new organization and have a ways to go. I do see a captive insurance company in our future, and within the next 6 to 8 months, we will be working out our strategy for developing the kind of culture you are asking about. As I've done with prior organizations, I hope to fund some of our risk and safety programs out of the captive, but that will take some time. We will begin programming in the highest risk specialties, OB, ER, and surgery, and we'll look for educational opportunities in the marketplace as well as internal development. We will develop playbooks for key risk and safety and will implement them across the enterprise as I have done in other organizations. But we are just at the beginning of that journey and have a long road to go. This is an individual who's taken me to school over the years. I'm sure that they'll do amazing things, but clearly in terms of transformation, integration, and onboarding, there's preschool. So let's move on to organization number 2. This is a Midwest organization with 17 hospitals, approximately 300 clinics in the three-state area. The conversation was with the Chief Medical Officer and the VPs of Risk and Quality. They employ 900 physicians, and they're 2 years into the implementation of the integration process. And so let's look and see what they had to say. What an organization will need in terms of physician integration depends in large part on their stage in the developmental spectrum. And I've got that on a conclusion slide. That was a great way to start this conversation, right? It really depends on where you're at. Organization number 1 was a 6-month spinoff. These folks are a couple of years in. We have just now gotten our arms around the basic new structure, and our current needs are dealing with basic risk and quality issues across all specialties. You'll see as we move on in maturity of these organizations how these specialties begin to play a much more important role. But for now, risk and quality issues across all specialties. We think of this stage of the process as onboarding, and right now we're looking for liability basics. We've decided to implement a curriculum of general risk-related issues, and we'll make that education mandatory for all employed physicians. We'll probably provide a menu of 5 to 10 important risk subjects and require the physicians to choose an agreed-upon number of those. We'll continue to review additional strategies as the organization matures. I do want to say that I don't know if any of the folks that we talked to are on this call, but I owe a great debt to these folks for getting on volunteering, and they did so because they are so committed to the National Risk and Safety Agenda. And they offered this to share and knew that that is what we were going to do. So I truly appreciate the time and the effort and energy spent by these folks. Organization number 2, these current general areas of concern they want to share with the enterprise. Risk nuances related to electronic medical records. Handoffs in care, ED to hospitalist, inpatient to nursing home, etc. Virtual space work is an interesting organization. Off hours, they are committed to a large telemedicine component of care. So they want to share issues related to virtual care with the entire enterprise. Helping providers understand what creates risk. Interesting. Documentation essentials. The decision-making process, avoiding cognitive errors. And we'll see that as a common thread throughout these organizations, the cognitive space. Transitions and care errors. And they were interested in education in high-risk service lines, and again mentioned emergency medicine, OB, and surgery, as did organization number 1. And they concluded by saying, we look forward to the process and view this as a work in progress and expect significant evolution over the years. So great. We've got organization number 2 a couple of years in. Organization number 3, really interesting. We're well on in our way from preschool to PhD. Very sophisticated organization, East Coast, 2 states, 10 hospitals, 2,000 employed physicians, both academic and community. And this is another one of those risk managers who I meet him at meetings year after year. I think I have some interesting things to tell him, and within a couple of minutes, he's just taking me to school. He's just telling me the way that it is. So I was very pleased when I reached out to him and said, would you share your process? Would you share where you are and what you're doing? He said, I would be happy to do so. So pleased he could participate. So they began the integration process about 5 years ago, and there's some interesting issues here about the need to integrate, and then in addition, what they've done in the risk and safety culture across the organization. So he says the need for a new construct was apparent, and they began aggressively employing physicians and buying physician practices. They knew that they needed to focus on population health and attention to wellness. And as we'll see, that's really a pillar in this organization, the next, and in the National Patient Safety Agenda, with a central focus on the patient population health. We recognize that our inpatient census would inevitably decrease as our outpatient census increased, and that transition is well underway. But the East Coast is incredibly competitive, and we felt an urgency to get out there and bring physician practices into our organization. These are many of them primary care physicians, and they were on staff at multiple hospitals, right? But in the new marketplace, they'll be committed to a single organization, many of them. And this organization was very keen on making sure they identified the right people and made them part of their organization. The first 2 years, we were just building, and now employ approximately 2,000 physicians. The next 2 years was about how to manage from a human resources and administrative perspective. We felt there should be limited variability in contractual relationships. So these folks are salaried plus incentive, 5-year contract. There are penalties for early termination. But the incentives relate to a range of risk and quality goals. Moving on, years 3 and 4, we addressed enterprise-wide issues. Very similar to what Organization 2 had done. Med-mal basics, insurance coverage, transitions and handoffs, EMTALA, HIPAA. But then it was time to move into compliance with quality metrics, reduction in practice variability, reducing errors and the failure to diagnose, and to follow the best evidence. So a very interesting progression along the spectrum of transformation. What did they do? Created a formal medical group to represent the employed physician, very connected to leadership. So for example, CV, ortho, neuro, emergency medicine, they're each organized into practice groups, each with clinical practice leaders. And he says it's very interesting now that we're 5 years into this, how clinical leaders have really stepped up. They've stepped into the organization. Talk about onboarding and transformation. Now it's the practitioners who are asking for hard information on adverse outcomes and incidents so they can do performance improvement. Interesting. Some additional points. These specialty teams are educating practitioners on standardizing care, quality metrics, performance-based reimbursement, hospital-acquired infections, etc. So some of it spans the enterprise, but the key that he was trying to drive home was that at some point in the transformation, it becomes specialty specific. He said, we continue to work on culture, who we are, what we represent as a system. And even though that's just a bullet point here, I think that may be one of the most important, I think it is the most important point of this presentation. Continuing to work on culture, who we are, what we represent as a system, and building safety, building a culture of safety. And we'll get back to that in just a moment. There are quarterly meetings between the medical groups and administrative leadership to get them down the road to decrease variability, to decrease failure to diagnose, to follow the evidence. And they strive for transparency among all leadership groups, administration, physician practitioners, and other administrative staff. Okay, organization number 4. Last but not least, large national organization. Again, incredibly appreciative that they were interested and willing to have this discussion. Over 15,000 employed physicians, an employment model since the inception. Our discussion was with the risk manager and physician VP of quality, and they started with culture. They're well into it. They've been doing it for years. And I was struck by, they started the conversation with culture. One of the keys in that culture is they have a National Adverse Outcomes and Incident Database, and they use that to study for trends and develop patient safety programs. Oops, sorry about that. But they shared with this with us right away. Here's our vision, here's our culture. When we onboard, this is what we are communicating to our physicians. When we communicate with physicians who are already on board and line staff, this is what we're communicating. These are the 5 pillars that this organization are foundational for this organization. And when we flip over to the National Patient Safety Agenda, we'll see that they've borrowed from the playbook or they've found certain common denominators. At the center is the patient and family. They said, however, this all rests on leadership. At the base of the pyramid is leadership. And leadership will talk patient safety at every single presentation, every single time. Up at the top, technical and cognitive competence are what we've learned in medical school, what we learn through continuing medical education. Over to the left, teamwork and communication. We're not learning this so much in medical school, unfortunately. That needs to be education. We need to learn teamwork and communication. My daughter just finished her residency training program in emergency medicine. They're starting to build some of that into education in residency in medical school. But teamwork and communication is largely something we need to be taught so that we can buy into that culture. Over on the right, standard work reliably implemented. Evidence-based medicine. What's the best evidence? How can we decrease variability? And the circle going around the patient is identifying and mitigating hazards, is reporting, is identifying problems and issues, redesign and preventing failures. Probably a 6th pillar in this organization. So I love the fact they start with vision and culture. Additional points. When we onboard physicians, they're educated in our peer review process that is reproduced at every hospital with minimal variation. So I think we're moving on here toward our PhD with kickoff with culture, with safety culture, and the onboarding process includes this is how peer review works, this is how it's going to happen at every hospital that you're going to be working at. Minimal variation. The organization is broken into regions. Regional orientation, each of the regions focus on our biggest pain point, failure to diagnose. 3/4 of our funded safety projects have a failure to diagnose focus. Those who think they have a good idea, they go to the organization and say, we'd like to develop this program, and they'll fund certain programs. And as it turns out, most of them today are focused on the failure to diagnose. Another key foundational issue is our focus on the cognitive space, the process by which clinical decisions are made. So again, we're seeing that as a common thread, how physicians think, understanding cognitive pitfalls, human bias, and heuristics. We're seeing this in the more mature organization. We believe that decision support must be part of the electronic health record, understanding cognitive pitfalls, understanding human bias. They believe that there needs to be clinical decision support, support of clinical decision making. an example of their regional orientation. Med-mal overview, duty breach, on-call requirements, obligations, potential for exposure to liability, EMTALA issues, med-mal coverage, curbside consults and related medical legal issues, documentation, pearls, pitfalls, copy and paste issues with EMRs, informed consent, disclosure and apology, major failure to diagnose clinical entities, medical errors, improvement methodology, that perhaps sixth pillar in this organization, improvement methodology, standardization and variability, and just culture. So that's the orientation for all new physicians, most of it live, partially online. But there's also a refresher for all line practitioners every 3 to 4 years. Evidence-based medicine development is a joint partnership between the medical group and leadership. Interesting, specialty by specialty, just like organization number 3. The process is sponsored by the medical group. They lead that process. Looking forward to standardize, everybody has opportunity. They're looking forward to standardize this on a national level, close gaps and variation in care, clinical protocols, medical devices, etc. So this is a relatively short presentation. There's so much to say about transformation, but these folks took me to school. They took us to school. It's the culture. It's about the culture. If the organization lives a culture of safety, the related integration and onboarding process flows naturally from it. In mature organizations with a vision and commitment to the fundamentals of safety, the practitioners are on board. In preschool, it's a struggle. It's herding cats. In these more mature organizations, they're in. The National Patient Safety Foundation has provided a wonderful guide to assist in the creation of that vision, establishing pillars of safety, and I see this in the second 2 organizations. And I'm not going to spend too much time on this. I'm not going to get into the weeds here, but this is brilliant. This is the NPSF vision toward the development of that patient safety culture. And I felt that this was a critical document, and I just showed you organization number 4, and I showed you their vision, common denominators. It's in organization number 4. It's the first thing they talked about, and there's 2 or 3 more pillars in this document that was published by NPSF in 2015, something that you should absolutely get your hands on and take a look at. So the integration challenge, and we'll finish up with this. Where are you along the spectrum of integration? Preschool or professor? Where are your sharpest pain points? Is it failure to diagnose, EMR, compliance, regulatory? Are you willing to invest in capable, empowered physicians and nursing leadership? Can you do this yourself, or do you need help? This is a big, complicated, sophisticated change, this transformation. And the organizations we talked to did part of this themselves, and they brought in consulting, and they brought in education. So they did some of it themselves, some of it they needed help. Take stock of your available resources and risk patient safety, performance improvement, and education. Do you have the right structure in place that will foster growth along the spectrum? Does your organization share the safety culture vision, whether you are early or late in the process of transformation? There are online curricula to consider for your physician integration strategy, whether it's an overview series by specialty, these general medical and legal issues and risk, patient safety fundamentals, patient satisfaction, performance-based reimbursement. These things are available if needed. Conclusions, and then we can open up to Q&A if folks have time. The need for transformation is upon us. Integration of the medical staff into the new paradigm is essential to safety, quality, and economic success. Clinical integration or onboarding, it's a dynamic multi-year process, as you can see. as we've been taken to school by Organization 1 through 4. It requires vision and a combined commitment to that new culture. And integration should be a natural result of attention to the fundamentals or the pillars of system safety. I learned a lot along this road, as always. These folks have taken me to school. I have really enjoyed this process. I hope I've conveyed an important message, and I hope that you can benefit by this. And at this point, Jen, I will turn it back over to you and open up for any questions that folks may have.
Dr. Sullivan, thank you so much for that fantastic presentation. I love how you wove in all that wonderful feedback from your peers. I think that was just great insight. As you mentioned, you have generously offered to stay on to answer questions beyond our scheduled 30-minute session today. But for those who have to jump off for other meetings, I just want to walk through a couple of closing points before we, while we're letting the question queue build. So if you have questions, you can submit them one of two ways. You can use the WebEx chat and chat your messages to all panelists, or you can use the Q&A if you're more comfortable using the WebEx Q&A. So we're going to let the chat queue build just a little bit, and I'm going to walk through just our last few slides here for those who have to depart for other meetings. If you have questions about today's presentation or about the XL Catlin TSG program, please contact Brant Roth at broth@thesullivangroup.com. We also will have a short form that pops up at the conclusion of the broadcast, and you can request more information or contact using that form as well. Please take a moment to share your thoughts with us. We do learn from your feedback, so you know that is important to us. And we are recording today's broadcast, and we'll have that posted up to the Sullivan Group's YouTube channel within the week. Okay, so now back to Q&A. So, Dr. Sullivan, I have a few questions here that I have built up in the chat. So the first one is, what are some of the basic risk and safety issues you mentioned that an acquisition may reveal?
Well, I guess all of them. It'd be nice to know before the acquisition what some of those issues are, but starting at the top, it may identify leadership that has not moved along this spectrum. Leadership who hasn't learned that patient safety is a culture that must be cultivated and be a part of this transformation. It could, looking at individual service lines, it could be that there are huge areas of variability in practice and that there is exposure in emergency medicine or obstetrics. That there have not been efforts made to standardize care, reduce variability, that there haven't been efforts to bring everybody on board in terms of patient satisfaction or hospital-acquired conditions or readmissions. Again, as I said, if you're acquiring, it would be nice to know before the acquisition what some of these issues are, and I would think you'd be looking to acquire hospitals that have already paid attention to many of these issues. So I think those are some of the fundamentals, but I think that the laundry list of things that you'd be looking at could be the subject for an entire new discussion. But I think attention to the construct, the patient safety culture from the perspective of this presentation, you'd want to know that some of those pillars are in place. Thank
you. So I I have one more question here in the queue that I have for you, and I'm going to call it the million-dollar question. But if you're looking to change culture, what's the first step you might take?
Oh, I think it is it is getting steeped, taking the deep dive into I think the National Patient Safety Agenda. I think what folks are looking for is in the NPSF publications. It's in the slides I just showed you from organization number 4. It's jumping in, and NPSF was one of those pillars. Says get leadership, get them all in a process, get them all educated, get them all on board. Organization number 4 and the NPSF white papers, documents, their plan for improving patient safety across the spectrum, clearly indicates that this all flows down from leadership. That is a part of every presentation, and I have participated in many of these over recent years, where I've been asked to do a presentation, but before I do it, leadership says, let's take a patient safety moment, and they'll give a vignette about a patient, or about a situation in the hospital, or about falls, or it could be anything. But leadership's attention to safety after they've been educated about the agenda and the culture, you absolutely need to start there. And I think that all stems from that.
Thank you. It looks like we have one more question here in the queue. So just to frame this one, coming from the perspective of the risk professional, what areas do you recommend leadership focus on after the HR and admin areas? In other words, what risk or safety areas should come first with your newly employed physicians?
Right. I think it was organization number 2. Organization number 2 is at that point, and they were looking for enterprise-wide education, things that they wanted to tell all physicians. Like I said, if you could wave your wand and get everybody on board, what would that be? And organization number 2 did it in the first couple of years. Organization number 3 did it in years 3 and 4. And those were electronic medical records, the strengths and weaknesses, and the basics of medical malpractice, and what causes risks, and the communication and handoffs, patient satisfaction, those sorts of things. I would love it if the answer was, get them going with performance-based reimbursement. And have them understand just culture, and get your medical leadership divided into specialties, and let's reduce variability. But I just don't think that that's practical in those first couple of years. It is those things that organization 2 and 3 paid attention to. EMTALA, it applies to all physicians on call or in the emergency department. They need to know about HIPAA. Got to know about HIPAA. So those things that are enterprise-wide, I think, are where you go at that point in the organization, years 2, years 3, after you've done your basic blocking and tackling for human resources, for contracting, et cetera.
Dr. Sullivan, thank you so much for those valuable insights. We don't have any other questions in the queue, and we've already gone over our time. So to respect your time, I will move to conclude today's broadcast. But before we do that, I just wanted to give you an opportunity to share any closing thoughts or sentiments with our group gathered here today.
Well, I think this is one of the biggest challenges we face, is this transformation. And as I read more, learn more, talk more with leadership in this country in healthcare, I recognize that there are going to be winners and there are going to be losers, and those who integrate and onboard and transform are going to be the winners, and those who don't pay attention to the subject matter of this discussion, unfortunately, won't be the winners. I hesitate to say that they're going to lose, but I think that attention must be paid, and there is a lot of concern that transformation is happening in some organizations, but many, many lag behind. So I think it's paying attention to the National Patient Safety Agenda. There are plenty of resources that are available. If you're interested in knowing what some of them are, things that we look at, things that the leaders I spoke with look at, then please feel free to give us a call, and let's have that dialogue.
Dr. Sullivan, thank you so much for those closing thoughts. We really appreciate your time here today, and we appreciate all of you who've joined us on this Friday afternoon. We hope you have a wonderful weekend, and we look forward to hearing from you. So that concludes today's broadcast. We hope you join us for our next event. Thank you so much.